My presentation is actually on percutaneous closure of sub-aortic and doubly committed VSD, a case series of a Bangladeshi center. So I have no disclosure. And this is the VSD, a very simple type of communication between the ventricles. But the thing is that when the location change, some of these become indication and some of these becomes contraindication for doing percutaneous closure. So here are some types. So if we can classify them like this, type 1, 2, and 3, and 4, you will see that the type 1 is the doubly committed or subarterial type of VSD. Type 2 is the perimembranous type, type 3 is the inlet type, and type 4 are the trabecular and muscular type. So initially, if we, so this is also the type of the VSD to understand. So the first one is the doubly committed type here, and then the perimembranous. So our topics today is how to device close these two types of VSD. So why we are talking about this type? Because we know when the VSD device closure was started back in 1998 by Locke et al., it was the closure of the muscular VSD. Then we knew at that time that PM VSD are the one which are contraindicated. But with time in late 90s, PM VSD were included in the indications, and nowadays everybody is doing this. And then after for last few years, we are seeing now that the sub-aortic VSD and doubly committed VSD, in many centers, people are doing device closure of these two kind of VSDs also. But these were previously contraindicated. So why these were contraindicated or why these were difficult? Because sub-aortic VSDs are immediately below the aortic valve and have propensity to develop aortic valve prolapse and aortic regurgitation. We all know that. And doubly committed VSD, actually, these are subarterial. There is no rim, there is no conal septum, only the fibrous annulus of the valve is there. So lack of subaortic rim and conal septum leave the annulus cell again, and there is not that much of the landing zone for the devices. So larger size device and stiffer kind of devices are not suitable for doing this kind of device closure. So if you see which kind of the VSDs are the contraindicated, contraindication for the device, you will see that doubly committed with presence of RCC prolapse, presence of air, these were once considered as contraindication, but now these are also included in the indication. And what are the evidence behind that? You will see from the literature. This is one from the Cardiology Young saying that surgery is good for the doubly committed VSD. And this is from the European Journal of Cardiothoracic Surgery. They're saying their outcome on the sub-aortic and doubly committed type of VSD. These are the studies from Southeast Asia, from the Indonesia, and from the China. They are showing that they have very good result on outcome of VSD in their series. So why we started doing this kind of VSD in our center, actually I must say that this credit goes to the care receiver who were our first patient when we did this case. So the story started in 2011 when we referred one of our female patient, 34 years old, to cardiac surgeon, and she returned with frustration, and she said, I don't want to do surgery, please try. You are doing so many cases, so please try on me also. So then we had a second thought, and we were thinking, how can we help this lady? So in that we started on her, and successful result on that lady encouraged us to do our next cases. And similar thing happened in 2014 when a doubly committed VSD parents, they came to us, they said, we don't want to do, and you please try. So we also had a second thought. We think about his weight and the proximity of the valves and other things. And then we said, okay, we'll try once. If not possible, then we'll refer him to surgery. And the success of that guy also, that child, actually encouraged us later to do more cases. So what are the types of the devices we are using for these kind of VSD, which are very close to the valve? We are not using muscular. So this is cross. We are using duct occluder one in some of the cases, which are very large. or amputated duct occluded to, or the cook detachable coil in some of the cases, and corner MA4 device. So these are the three devices which are most commonly used in our, we are using for this kind and are used in our series. So why we are AD1 we are using, because axis is smaller. The delivery system 6 is almost actually good for all the devices, and congenital heart block are very rare. We have never experienced, and also in the literature, they have not experienced any congenital heart block, complete heart block. And this is less expensive as well. And equine angiography guideline is very good for doing the case stance. Esophageal is not required. And escalation of the size 1 to 2 millimeter is enough. Then limitation is what? It is not actually designed for the VSD. And it is good when there is tricuspid valve aneurysm. Other than this, it is sometimes difficult. And it is also difficult if there is pulmonary hypertension, because this is a single disc device. So if there is high pressure on the other side, there is sometimes chance of embolization. And ADU2, which we are using mostly, is it is soft one with wide waist. Complete heart block is also not reported yet, and it is very easy to deploy because there are 2 screws, and retrograde and antegrade is possible in this case. And what are the limitations? Length of this device is little bit of the limitation. We have LVOT obstruction in only one case, and that was due to the length of this device. So, and another limitation is highest size is up to 6 millimeters. So we can't close more than 5 millimeter holes with this device. And then the Konar MA4 device, it is the most useful one for doing these kind of cases. It offers a vast variety of options by allowing different approaches like antegrade, retrograde, even through foramen ovale you can do it. And larger size are available. This is the most, I must say that this is the most important advantage of this device. And size of the delivery system, even we can deliver it through the coronary guide catheter. And complete heart block not yet reported. So this is the one, I must say that this is the game maker, because after getting this device, we have started doing so many cases which we are not doing before for the fear of having a heart block, encroachment of the aortic valve or pulmonary valve. So this is some of the cases from our case series. But I must want to share some of the facts of this series, why we have done these cases, because doubly committed and subarterial VSD, these are very common in our population. About 30% of the VSDs are subarterial in Asian population, and incidence of aortic valve prolapse is as high as 30% in this group of the VSD, and absence of the muscular attachment and support of the sinus of Valsalva with the ventricular septum results prolapse of the aortic valve occurs very easily in this kind of the patient. And in subaortic VSD, AVP occurred in diastole initially, but later it also occurs in the systole, and it caused further damage of the valve. And absence of the conal septum in doubly committed VSD cause also is a cause of aortic valve prolapse. So early closure of this VSD can prevent progression of the aortic valve prolapse as well as aortic regurgitation, and can prevent these complications. So for successful device closure of this patient, we need the true measurement of the VSD, as there is not that kind of the subaortic rim. So from where we should measure the true diameter of the defect. So in subaortic VSD, true defect should be measured from the tip of the subaortic rim of the aortic valve annulus to the crest of the interventricular septum. And for doubly committed VSD, we did the cases which are only less than 5 millimeter, weight is more than 15 kg. And as there was no conal septum, the VSDs continue with their upper margin with the fibrous annulus of both the valve. So true defect in this kind of VSD is measured from the fibrous tip of the interventricular septum to the tip of the fibrous continuity, and there is actually not that much of the landing zone. So because of less space, device size is escalated here up to only 1 millimeter in most of the cases. So subject was about 103 patient. Study place was Pediatric Cardiology Department of the Levitt Cardiac Hospital and Bangladesh Specialized Hospital. and study duration was about 2 years. Total of 103 cases had this kind of VSD, and there were many more, but because of the weight, because of the size, they were excluded. And procedure was performed under deep sedation. Approach was retrograde in most of the cases, in 95%. Heparinization was done fully. Aspirin was given after the procedure for 3 months. We have not given 6 months. We have given only for the 3 months, but there was no problem. And inclusion criteria was sub-aortic and doubly committed VSD with trivial or mild RCC prolapse or trivial or mild aortic regurgitation. Exclusion criteria was VSD with direct margin over the cusp of the aortic valve, and doubly committed VSD more than 5 millimeter, and sub-aortic VSD with like more than 6 millimeter. Moderate to severe RCC prolapse were also excluded, and moderate to severe aortic regurgitation were also excluded. And these are the equipments required, you all know. And diameter of the device, as I have mentioned, it was only 1 and maximum 2 millimeter larger than the true diameter. And for sub-aortic VSD, we formed arteriovenous loop for few cases only from the jugular venous approach, but most of the cases we performed it in retrograde approach without forming any lobe. So I can, for the students or those who are very new, retrograde approach, I can show you quickly.
Time is over. Can we go to the results and conclusion?
Time is over, or I am finishing then. Okay, so this is the actually the age group is 3 to 5 years, and weight is 10 to 20 kg. And about the outcome, I'm going to my outcome slide now. And you will see here that in the outcome, complete occlusion was in sub-aortic VSD out of 70, 66, and in doubly committed, it was 88. So it was about like 92% success rate. LVOT obstruction was 1. Embolization was 2 in sub-aortic VSD, and there was no other complication like arrhythmia, shock, etc. So because of the time, I can't show you these cases. So only one video maybe I can show you. So this is the one in the doubly committed one, and maybe one of the NGO video I can show you. So this is, you can see here that just below the aortic valve. Time is finished, or yet 1 minute or something? Finished already?
Yes, sir.
Okay, then I'm going to the conclusion slide. So these are all are the cases of doubly committed and other VSDs. And I'm going to my last slide now. So actually these are difficult procedure, but can be performed safely in centers. So device closure of sub-aortic and doubly committed VSD is a common complicated procedure other than other VSDs, and vicinity of the valve apparatus and the moderator band, chordae tendineae make it more difficult. Encroachment of the aortic valve or tricuspid valve within the device cause serious hemodynamic impairment. So our study proved that percutaneous closure of sub-aortic and doubly committed VSD in selected cases are safe, effective, feasible technique under transthoracic echo guide even, and without general anesthesia and without need for stay in ICU. However, large-scale studies still required for long-term recommendation and strong recommendation. These are the reference from India and Pakistan. And thank you very much, PCSI team 2022 Kolkata. Thank you.